Thank you all very much. We really appreciate it. Fantastic. They'll all be around for the rest of the week. Again, and Dr. Sussman, I apologize for giving you the gong so quickly.
It happens to me all the time.
So we're just going to power through our next session, and then we'll break for lunch. We'll break a little bit early for lunch. This next session is more of an administrative session, and we're really, really fortunate to have our thought leaders here from the various services. So we're going to hear a little presentation from Air Force, and then our Navy colleagues, and then our Army colleagues about where we're going in the state of pain in the system, and where we're headed to and where we are now. And with that, I'm going to have Colonel Caesar Juncker come up. Colonel Juncker is a family physician, sports medicine physician. He's the head of the Air Force both pain and integrative medicine program, and most recently he has stood up a interdisciplinary pain, TBI, and PTSD center in the Panhandle. So that would be at Eglin. So with that, I'm going to turn it over to Colonel Juncker.
Thank you.
And your slide.
Actually, let me see if I have let me get my watch too. So I can
And as Colonel Juncker starts, I will have his slides up momentarily.
Thank
you. Want to just go ahead.
If Joe and the other two guys want to come up, you guys can come on up too. Just I'll start before my slides come up, trying to give you a little bit of a story on how I came to where I am, the position that I'm in right now. So about 3 years ago, our Chief of Staff of the Air Force, General Goldfein, decided he wanted to improve care for invisible wounds, which are TBI and PTSD.
You want to switch with me, sir?
Sure.
Thank you.
And and why did he want to do that? Well, he was shot down over Kosovo in 1999 and was picked up by a PJ. His name was Andy Kubik. And the story goes that basically he kept in contact with Andy for years afterwards, and Andy was discharged from the military for mental health disorder. And what ended up happening was he ended up going into multiple treatment programs for mental health disorder, as well as encounters with the law, et cetera, et cetera. As it turns out, he actually had probably something more similar to schizoaffective disorder than he did any particular PTSD or TBI problem, but it doesn't really matter. The bottom line was that he was trying to bring attention to how we treat patients with mental health disorders, and actually specifically he was concerned about suicide rate. And so from there, he tasked our Surgeon General, which is General Ediger, who's a family physician and very much a believer in integrative medicine, who came to me, who I was in SOCOM headquarters, and we have a program there called POTIF, Preservation of the Force and Family, which is very much a kind of an interdisciplinary integrative medicine way of taking care of patients with multiple problems. And so I came in kind of not knowing where I was going to start, but I start to look at all the different services and all the different things that we're doing in the military right now. And so the first thing that came across my plate was this Intrepid model for taking care of patients with TBI and PTSD. So the first question, I just was wondering, how many people have heard of the Intrepid Spirit model or NICO, have just even heard of it? So I'd say maybe 40%, 30-40%, and I'd not heard of it either. Essentially what it is Mr. Fisher, who you guys heard, the Fisher House, started a program where he was building a building, and we would provide the providers to take care of patients with TBI and PTSD, specifically using an interdisciplinary model. So oftentimes it was PM&R, neurology, primary care, PT, OT, speech language pathology, vestibular care, all sorts of different providers coming in to evaluate a patient, with the notion of the fact that if we saw these patients individually, if each provider saw the patient individually, they'd come up with a treatment program. And then they'd have to collaborate. And anyone who knows taking care of patients, that when you do that, you have multiple treatment programs, no one coordinates and no one ends up really getting a good plan to the patient. You know, even as a primary care physician, you're oftentimes referring out and trying to get what one person's saying back to the patient, and you get, you know, basically a story from the patient is probably different than what the provider, because of communication gaps, et cetera, et cetera. So the NICO, or the Intrepid Spirit model, is that we see the patient together. In other words, all the providers see them together. And I think that just listening to lectures early on this morning, I really felt like that was a message that you could kind of see, is that there's all these different ways to take care of patients. Cognitive behavioral therapy that we talked about just recently. There's integrative medicine modalities like, you know, in acupuncture, PT and OT, and all of these different, we'll say, treatment modalities come into play when you're trying to take care of a patient, especially when we're talking about someone who has pain. So from there, to make a long story short, we decided to open a center very similar to the Intrepid model down at Eglin Air Force Base. And Scott King is actually here, who's a pain doctor down there. And I flew down to Eglin Air Force Base and met Scott. And, you know, I think the first thing you need whenever you go to start a clinic or a model like that is you need a champion. And he was a great champion for, number one, not just because, you know, he's a pain doctor and he's, you know, basically very, very interested in taking care of patients from the holistic point of view. He's actually acupuncture trained too as well. But just a nice guy, you know, really wants to take care of patients and wanted to, you know, I think help create this program. And that made it very easy for me because, you know, I had to convince the leadership down there, which wasn't easy, that this was a fruitful effort. So with that, let me just go ahead and try to race through these slides. And the reason why I brought this whole thing up was because of the interdisciplinary model of taking care of patients with pain. And basically what oftentimes referred to as integrative medicine. So General Edgar really believes that integrative medicine is probably the way that we should try to address this opioid crisis. And so I'm just going to go through this as our initiatives in the Air Force and how we are addressing kind of our pain epidemic. So Air Force SG acupuncture and integrative medicine aim goals. Current initiatives, the one that I just mentioned at Eglin Air Force Base, which is in the Panhandle of Florida. Joint Base Andrews Acupuncture and Integrative Medicine Center expansion. So we have a center of integrative medicine at Andrews Air Force Base. And so we have, I think, 3 or 4 physicians. We're going to make that into a staff of 10. And they're going to basically push BFA out into all 75 Air Force and MTFs. The next program that we're doing in the Air Force is acupuncture and integrative medicine at family medicine residency programs. So we have 150 family medicine residents now, and our center at Nellis Air Force Base uses the Helms course to train their second-year residents, and we're trying to expand that to all family medicine residencies so that everybody that comes out of a family medicine residency program will have the opportunity to go through what I'm going to say is a medical acupuncture course, which is, you know, essentially refers to the 300-hour course that Helms teaches, or McMaster's, or Harvard, or there's a San Francisco course that you can do it in one setting. Future initiatives are medical acupuncture and BFA into other residency programs, DoD integrative medicine course, which I'm going to go into at the end, and a CBA, which stands for capability-based assessment and DOP-MIL PFP analysis to develop CONOPS for a full integrative medicine, full integrative and pain medicine program in progress. I'll probably spend less time on that. So Eglin, we're going to be opening up this clinic in the summer of 2018 in a 25,000 square foot temporary facility that will eventually transition to a hard facility over the next 2 years after. The focus is going to be on patients with symptoms of TBI, PTSD, and pain. So unlike the the Intrepid model, which really is a TBI center. I think mostly that's what we're centered on, trying to take care of patients there. We purposely put pain as the first diagnosis that we're going to be taking care of, and centered it at the pain clinic there. Working with the AIM clinic at Andrews Air Force Base to develop research protocols. I'll skip that last one. So this is the population down at Eglin, and that's the reason why we chose it, mostly because of the special operations community down there, and there's an EOD schoolhouse. These are some of the services that are developed or offered at Intrepid model, which is vestibular, sleep, academic, music therapy, vocational, acupuncture, cognitive skill building, yoga arts. This next slide, I wanted to kind of focus in on integrative medicine and how do we define integrative medicine. So the National Center for Complementary and Alternative Medicine at the NIH, integrative medicine is something that combines mainstream medical therapies and complementary and alternative medicine therapies for which there is some high quality scientific evidence of safety and effectiveness. In other words, integrative medicine cherry picks the very best scientifically validated therapies from both conventional and CAM systems. So I think that's a great definition, because we're really focusing on evidence-based medicine when we're saying integrative medicine. And so from that, or before that, General Edgar, when he was testifying on the Senate floor, was asked, what are the services doing to look for alternatives to opioids in the treatment of service members' pain? And he responded, the Air Force is targeting integrated medical approach, including acupuncture training and other integrative medicine modalities. So for us, when I say integrative medicine, one of our biggest focus is acupuncture. And I just like, just by show of hands, how many people have practiced acupuncture out there right now? So a little less than half. How many people are, quote unquote, medical acupuncture or licensed to practice acupuncture in the state of their license? So I think maybe 4 or 5. So that's great, because I'm going to use that statistic on my efforts. But essentially, I'm presuming a lot of the other people are practicing BFA. Is that correct? Or dry needling, or is that correct? If anybody else is doing something else, let me know. But what I think is important is that I think one of the other speakers mentioned this earlier, was how we try to make, actually it was Commander Milligan said, we try to make things more complicated than they necessarily need to be. And acupuncture is great. We don't necessarily understand why it works in many cases, and there are so many different techniques and different ways of teaching it, whether it's the traditional Chinese method or whether it's kind of a Western approach like they do at the McMaster's course, or just teaching someone BFA or auricular acupuncture. I think that we all know that it works. We're not quite sure. And so therefore, I really think we need to get it out as much as we can, as quickly as possible, without trying to worry about the quality assurance, which is what, you get a lot of, and I'm up already. So let me just race through the rest of these slides and just give you a little background on the okay, so this here are some of our future initiatives. One of the things that I was tasked to do was to develop a medical acupuncture course. So General Edgar, this is actually a memorandum that's going to be coming out in this next week or two. Can you read it? No. Essentially, it's a letter to the Uniformed Services University president and the dean, as well as to the DHA Ops, which is Major General Clark, to task them to start a tri-service DoD course. So the goal is to be able to, one, have within the DoD acupuncture training. So instead of sending people out right now, which costs about $10,000 per student to send someone to like the Helms course, we're going to actually try to do it in-house, and the program will be probably centered at Uniformed Services University. So that's a new initiative that will affect all of us throughout the services. This was just a slide here to talk about that we're trying to spread it to the other residency programs too as well, internal medicine, neurology, emergency medicine, anesthesiology. Anyway, so questions? Go ahead. I can hear you.
Countries working at Germany right now. I have a question for you. Instead of training MDs, why can't you guys bring more acupuncturists? Let's say if you do part-time, let's say one patient a day, you're not going to get better. The training just starts. If you do it every day, it gets better and better. I mean, you say the acupuncture, you can take better field acupuncture, easy ones, but like you're saying, there are many different techniques. That's Andrews. So it's better. Let's say you try acupuncture for anyone, right? You get like 50%. It's like 50-50. That's what we learned after when we graduated from acupuncture school. The more you do it, the higher percentage goes up. You better 70-80. So sometimes you work, sometimes it doesn't, because it's 50-50 if you do it without special training. So you want to get to 70. Good ones are 70-80%. So that's really big difference. So I just don't understand how come at the system bring more professional acupuncture instead of training MDs.
Are you a licensed acupuncturist?
Yes.
So you're a LAC. So just for the audience, there are essentially two types of acupuncture, we'll say, providers in the U.S. now. One are called LACs, or licensed acupuncturists, and then the other set would be what we call medical acupuncturists, which are usually a provider, and for the military's sake, is a MD that is trained in acupuncture. And the point that I think that you're bringing up is that, unless you're doing it full time, you're going to have poor results, or not as good as results as someone that's practicing it full time. And I would say that I've already had a lot of that information come to me. My goal is actually to try to deal with that circumstance. The medical acupuncturists also believe the same thing, that they should basically, that people that are practicing BFA and other types of acupuncture without going through the 300-hour course should probably be limited in their privileges while they're practicing. And I'm actually of the mindset that we should try to get it out as much as we can, as quickly as possible, and that efficacy, as you're saying, that could probably be 50-50 sometimes, but in the hands of a LAC, you're saying it's much higher, 80-90% or something. I think that that's not a reason to try to get it out there as soon as possible. I think that, anyway, that's basically what I would say. I appreciate the comments, and I think that they're very valid, and certainly I've heard that from the other providers in acupuncture.
I see Chris is over there with a hook, or one of those things.
I should have brought my Theracane. So
if you're done here, we're good to go. Otherwise, I had one question/comment that I was just looking through the agenda item, and I see we have a ton of great workshops this afternoon. What I'm looking at, when I see these workshops, I see a bunch of tools that are available to us as providers to be able to utilize to take care of our patients. What I'm not seeing, however, is what you started on, but I'm not sure you finished, which is a construct of how to deliver that to our patients. And the reason I talk about the construct is that, first of all, most of the patients that are being issued these medications are not from surgery or specialty clinics. They come out of primary care. 92% of all opioids are prescribed by primary care physicians, and then most of those modalities come through primary care. So as we build these tools, how does a primary care provider protect his patient, protect himself from his patients, protect the organization from the patients? I had a chance to meet with General Edinger and then also with General Clark, and I sent them information papers, and I passed my compliments to Lieutenant Colonel Air Force Dr. Nate Evans for building a construct of Evans Army Community Hospital where we had primary care providers with subspecialty expertise in support of primary care providers who are taking care of their patients. And we built a very elegant structure of community support where the primary care doctor would meet with 3 other primary care doctors to talk about their patient, and behind those 3 primary care doctors was behavioral health, clinical pharmacy, family advocacy, If we could find an addictionologist, we happen to have an expert pain manager that would also sit in the room and provide advice. That structure gave primary care providers power to do the right thing for their patients. So as I look at this integrated medicine approach and all the things you're going to teach, integrated medicine is absolutely right, but integrated medicine as a singular tool without this larger construct doesn't give power to providers to change the methodology of work. So I was going to ask Chris, Nate's flying this afternoon, and I'd love to volunteer him when he's not around. But I would recommend a short discussion, 20 minutes, 30 minutes, on a construct that these people can take back to their home stations to build a team that allows them to be more functional in narcotic reduction and pain management writ large. Thank you, Chris. It's more time than I deserve.
Thank you, Colonel Birchfield. I think that that's very, very poignant, very really on the spot when we're talking about translating from basic skills to really population health care. And I think what I'm going to do is I'm going to now turn it over to Dr. Phillips, Joe Phillips. Joe says just Joe, because maybe we can incorporate that in the last, a little bit of that in the last several minutes that we have before lunch. But very important comments, and I think that, deserves a workshop in and of itself. And maybe you've just volunteered yourself for a workshop next year, back in your own stomping grounds. So.
As long as the team supports it.
So with that, I'm going to turn it over to Joe Phillips. Joe has an outstanding, a very distinguished career in the Navy, and has transitioned to a civilian, is our program manager for Navy's pain programs. Joe is a thought leader for pain, again, in more population-based in the MHS, but not only in the MHS, and I think nationally. And we're very fortunate, Joe, to have you today speak with us. So thank you, and I will give you your 5 minutes. No.
Thank you. Understood. So while those are loading, if you guys can hear me, if everyone, I know, we're how do you say, shaking and moving. If everyone could just take a quick second, all right. Humor me while we do just a breathing exercise. So if your hands, try to sit up straight in your chair, get good posture, and then place your hands on your knees or on your table, typically kind of on the knees from what I hear about these breathing techniques. Close your eyes. I won't say don't think of anything like pink elephants. And I just want you we're going to take 3 deep breaths. Just inhale, take a deep breath, hold it for just a second or two, and slowly, controlled release. Exhale all the way out. Try to use stomach breathing versus chest. Let's do number 2. Take a deep breath. Hold and release. Slow, easy. One more. Take a deep breath. Inhale. Hold. Release. Relax. And open your eyes.
I have.
Right.
This is
And I'll tell you the point of that as I close. Now I have 5 minutes. So what I want to do is tell you there's no disclosures, no financial disclosures, not getting paid. This is Joe's opinion and not Navy or Navy medicine, though I do work for Navy medicine. I like a lot of the things we've heard today with the biopsychosocial model, the approach. One of the things I really want to get to, and Colonel Birchfield, you tagged on something. So I'm going to show you a model here, kind of an approach. We've heard that unless you change the system in which we work, how we operate, the availability for primary care providers to see the patient and do what they need to do, it's going to be very difficult. So I'll try to ramble through these really quick. Navy comprehensive pain. All right. My disclosures, disclaimer, nothing to show there. All right, our mission and vision, simply put, our mission is to be an enabler. So from a program perspective, we're here, we want to target primary care and carry that throughout the continuity, throughout secondary, tertiary, whatever the patient needs. But we believe the patient has to be empowered to self-care and also buy into that treatment. The vision ultimately, we have a dual mission, as they would often say. We're here for the warfighter. If there's not a military wartime requirement, we're not in uniform. Well, so we have to worry about readiness. That is something we focus on for Navy medicine, and I believe the other services are doing that as well. This here is simply to say, if you walk down, there's a lot of directives and policy that generate this, that started these efforts. This didn't happen by random chance. It wasn't a fluke. Congress said, hey, there's a problem. We need you to address it. Here's money to do it. That's one of the reasons you guys are here. This is funded. You guys are here. We're trying to take these initiatives and move them forward. If I go too fast, let me know, but I don't think Dr. Spivak's going to say that. So I'm kind of streamlining this, so bear with me. All right, so one of the things that I do want to focus on is that out of the NDAA 2011, also the DoD Task Force on Pain Management, initiated by General Schumacher, and we have a lot of folks that were part of that, came up with like 109 recommendations to say, here are some recommendations to improve the consistency and the management of pain. So we're taking that. We want to have CPGs. We want to empower our docs with the tools that's needed to go out and do that. That's backwards. All right. I didn't have my updated slide on here, but in some of the, I should have looked at this earlier. So I looked at it on my screen. It looked good there. So basically, all this is saying is that from primary care, from before the patient ever arrives, we're trying to look at this biopsychosocial model. We're looking at the socialization. We're looking at the patient behaviors. We're trying to empower the patient to own their own care. So before they walk in there, and that comes with education initiatives for patients and providers. But if you draw another circle around this orb or this big egg, and you look at it, we put the patient there because the patient should be a part of that. Instead of walking in and saying, Doc, how are you going to fix me? What are you going to do? We know the societal norm is I'm going to walk in, you're going to give me something, I'm going to be good. I'm going to walk out and I'm done. Now, how about you, the patient walks in and already understands some of the things they can do? All right. So I won't spend too much time on this one before Dr. Spivak comes and gets me. But at the bottom right, you should see on there that it says the goal of this stepped care model, the patient stepping up from self-care to working with the primary care doc, to then the primary care doc helping to be an advocate for that patient and tying them into CAM modalities or, integrative modalities, tying them into other behavioral resources, tying them into mind, body, things like that. And then if we can retain, recapture a lot of that care within the primary care setting, better educate our providers so that they understand what their boundaries are, what they can do, how they're empowered to do that, and then only send up the most complex patient to the tertiary docs. Maybe we can recapture some of that. The majority of cost rolling out to the network is often because our tertiary levels are overwhelmed and they have to take the ones they can, refer the rest out. So that's happening. And the prescribing levels or the amount, as General Clark would agree, is that primary care prescribes a lot of opiates. So now what do we do to empower, educate you, prepare you? And so the Navy's taken a lot of initiatives, including a policy on kind of standardizing that approach called the long-term opiate therapy safety policy, which is in staffing, and hopefully we can get that out quickly to you guys, to the Navy anyways, and we're sharing that at the Tri-Service. So Colonel Yunker and the Army Pain Program Office, we're sharing all of these initiatives and efforts so that we can start aligning across the services and we have that common approach, that consistency, regardless of where the patient is seen. Here's our focus areas. So looking at clinical capabilities, we want to make sure that patients have access. And we said patients, not just active duty. We know the primary target is we're going to take care of our active duty so they're ready to fight. They can go out and do their jobs. But we also realize that their families need to be taken care of as well. Now, how do we do that when they're saying reduce funding or reduce your spending? I think we're at like 17% of the GDP, healthcare cost spending is. It's only like 2.8 trillion or something like that. just a drop in a bucket. But that's a lot of money, and they're saying reduce that, and oh, by the way, see more patients, do more, and do it in a lower time. So we're really trying to focus in on educating the patient as well. And so you'll hear more about that, I'm sure, as you go through. Clinical guidance, looking at the CPGs, kind of for our IOPs, for our other efforts, standardizing that and equipping them. Backing up on clinical capabilities, staffing. So we want to make sure that if you have the acupuncture training, or maybe you get a licensed acupuncturist, or you get somebody with some mind-body training and things like that, we want to equip at the primary care and secondary level, we want to make sure those resources are available. So saying, I've heard the question, well, how do we make sure patients get that if it's not there? So that's one of the approaches we're taking. So you're not just educated on what's out there, you have access to it. And so does your patients. Now that is going to take some time, and it's going to be a challenge, but we want to get there. Training and education, I believe that's key. And also for the patients. Patient safety, talking about that long-term opiate therapy instruction or OPWARD. What we're doing is looking at that, and we're identifying the patients that are on these opiates, the concurrent benzos. We're doing that and then providing it to our MTFs so that they can actually go out, engage those patients. We're putting clinical pharmacists out there within the primary care supporting them so that they can go and be an advocate for that and help with that effort. Performance management, leadership's always asking, well, how effective is your program? You're getting this money, what are you doing with it? So we're looking at that, we're looking at the trends, not just looking at trying to reduce opiate prescribing, but trying to just look at maybe utilizations and adverse outcomes and things like that. And then finally, change management, trying to make sure we're got that. That is my last slide right here. I want to point out the Kung Fu Panda. I just love them, and it's not a negative thing on acupuncture. I just love Kung Fu Panda. So there are so many thoughts and approaches to what integrative medicine, to what pain management is. That's a lot of what's out there, but you're helping to shape that. And we're going to, for the Navy, we're trying to start with the primary care and create that. And Colonel, we are actually piloting some things out at our Portsmouth network on what you're talking about, putting folks there and then creating that pathway for patients to be seen, treated, and the primary care docs to be empowered. So thank you for your time. I'll be here all day if you have questions.
Thank you, Joe. And our final presentation this morning is from the Army standpoint, and it's Major Ali Tarabi, head of our pain clinic here at Lawnstool, and Dr. Scott Griffith, who is the Army's pain consultant. And in looking at brevity, I won't give their bios. Dr. Tarabi gave me his bio, and it did mention how they have the best RVU production of all the pain clinics in the MHS, and it did go back to even his high school awards for best hair. But leave it at that. I turn it over to Dr. Tarabi and Dr. Griffith.
Yeah, I'm Ali Tarabi. I just want to also mention I'm the European pain consultant. So if any PCMs have any issues whatsoever, please come find me after this. I'll give you my card. We're open to trying to help as well. And then Colonel Birchfield, you had mentioned the construct, and I think this is very important. And we sort of already have that model, which is called ECHO, where weekly we discuss difficult patients with physical therapy, massage therapy, acupuncture, pretty much every specialty modality that we have, and you call in and discuss. You can be anywhere, and you can either call in audio or by video, and that is, we're always open to having more people call in, and you also get CMEs from that as well. And then I'll just have Dr. Griffith, who's basically the Johnny Depp of pain, talk, and then I'm going to show a short video.
Unfortunately, I'm neither Johnny Depp nor was I even high in the running for best hair. This goes back for a period of time. But I did want to ask a quick question related to this. We've had a lot of theft going on today, so I want to make sure and ask if anybody realized that Joe Phillips was actually with the Army before he was with the Navy. There's been theft of slides. There's personnel as well. But I did want to go back to the concept he brought up before we give you just an update on what we've kind of been doing in Army pain management. And another quick informal survey. Who knows what the step care model is? Like even predating what he just showed you, which would be a newer proposed incarnation of that. No wonder we hired you away from the VA. Not even the VA people are raising their hands, but that's okay. So like the step care model is something the Army and with the other services back in the pain campaign plan circa 2009, when this kind of all started in several of the and I think all of the services, was something that the VA had been doing. And I did want to bring that up because that's the sort of the 30,000-foot view. I think it is what everybody should know. So the idea is, as already brought up, most of the pain care is going on at the primary care level. So even if I was better than I am, if I did a really good job, I would still fail miserably because look, we're only dealing with a small subset of the patients. So the model is that you educate primary care providers, make them more capable, give them better teams, and we talked a lot about that today with behavioral health and pharmacists and physical therapists and occupational therapists, and I'll leave somebody out if I try acupuncture. So there are these teams that we need to make things work at that level because it works better when we're able to treat people closer to home when they only have one provider team to go visit. But then in support of that, we have primary care pain champions that then have additional capabilities, additional training that can help, again, embedded right there with those primary care providers. And then the third level of that system is the subspecialty clinics where we have the IPMCs in the Army and we have similar structures in the other services. And the reason I wanted to make sure everyone had that idea is because I have heard a couple of questions that bring up the idea of, well, what do I do with a person if they've kind of failed all this? And the dirty secret is the answer is a little bit different from service to service. We sort of adopted more directly the IPMC model based on our patient population sizes and based on the assets we had in terms of subspecialty. The Navy had a different model that I've been in most of the time working at Walter Reed. We had a hybrid model there where they had a better percentage of subspecialists. They would actually send subspecialists down and embed them in that, and certainly that's not unique. We've done that. Dr. Spivak originally worked embedded over before we moved buildings at Walter Reed as a pain subspecialist in the primary care wounded warrior setting, and that has proven to be effective. So these models that we're trying to work through, it makes some sense how we've got here, but it's understanding that there's confusion from the standpoint of we so far haven't done things exactly the same in these first 7 or 8 years, and that's one of the things we're working on now that Joe Phillips was talking about. So aside from that little background, I did put together some talking points of the new talking points that they put out from the Army, and I sent them to Ali, who I know well. He's one of the guys that trained with us, and he sent me back and said, this presentation kind of sucks. We need to work on this. So I'm going to turn over to you the presentation as he fixed it. And I think you'll find that much better than my slides that I'll show you after, but certainly if you have questions on the official Army slides, I'll try to help with those.
It was blocks of PowerPoint slides in 12-point font, just from here to the top. So this is a little bit different. And then afterwards, if you guys could fill out a survey and let us know whose presentation was better, Army, Navy, or Air Force, that'd be great. now the slides.
Now for those 12-point slides. So again, I have the talking points here. I tried to see whether I tried to see whether I should have the disclaimer slide, but the Navy had already hired Joe away, so I'm not sure if this is the official position or not. So I have not financially benefited from this, and Dr. Spivak was away. He has some background in law and helps us in our program a lot. So I just went on the fact that he usually told us if we weren't sure what to say, just not to say anything. So I kind of moved on at that point. So we like demotivator posters, and I know there was a question about spirituality earlier, so I did have one of my demotivator slides that goes along with that. But hopefully we've been doing a little bit better job than that overall, and do want to bring up some of the big processes that we've been doing. So this is actually a pretty important thing, is this idea of teams, and that's kind of what we're doing here that's different than other places. It goes back to what we were talking about with the Air Force as far as integrative medicine. Like, I define integrative medicine now as everything but opioids, and I think a lot of people are coming to that conclusion. So groups that traditionally haven't worked together because of the way they were financially reimbursed on the outside now have more of a compelling need to, and we have a unique opportunity because of the way that as a group we're paid, the way those things, to work together in settings where other people will not, and that will hopefully be something that will provide some of that evidence that we talked about later as far as the evidence-based approaches and maybe things that traditionally didn't go together can go together. But all of these things, and you don't have to keep this with pain, if you listen to General Line talk about trauma teams and how they're doing, they're like saying this, and I believe this is very true, and why we need to do what we're doing here at these times of these practical trainings. You can't just send the surgeon out to the civilian trauma center where they have a high volume of trauma. You have to send everybody out. You have to send the scrub tech and the nurses that are working with them, and that's something I think we'll continue to see. And then readiness remains job one, and this is kind of put in Army terminology like we're charging Hill. I always enjoy that, find it a little bit humorous at least. But this kind of puts together some of the things we're doing and where we fit into the larger scheme of things for the Army lines of effort. And these are some of our comprehensive pain management pieces that we really want to pay attention to. Leah's already highlighted our 50% reduction in chronic opioid uses and these various initiatives that we put forward to do that. We've had substantial decrease in opioid use disorder, and I would say we've also had improvement in the options for treating that sort of a problem. Now, one of the things most of you are probably aware of, I am going to slide through some of these slides pretty quickly, is the changes in the profile system. Has everybody gotten some sort of education on the changes in the profile system related to opioids? That's good. That's Army specific, so like the other folks, I would be concerned if you did. But for profiles now, in very specific terms, when a patient's put on opioids, they have to be put on profile. It can either be tagged on for short periods to an existing profile or a new profile, and that's how this relates to readiness, because opioids are kind of a no-fly zone without a waiver for a deployment to the war. So that's something I would encourage everybody to go ahead and look back into those. That has come out as an official directive, and look back up and try to get some more education. Yes, sir.
Just on that topic, so my team is responsible for deployment waivers for Europe. If you're on opioids, you will not be waived. So that's a big change in policy. If you want to send your guys to rotating forces in Poland or throughout the new Warsaw Pact, and you want to put in a waiver, we are not approving those waivers for long-term opioid use.
I'm getting the Theracane from Chris, so I'm going to move pretty quickly. And a shout out to our pharmacy friends for the success of the CHUP program and contributing to decreasing the opioids. This is talking a little bit about PASTOR. If you're familiar with that, Promise is an NIH product. PASTOR is basically a computerized system that is hopefully going to allow us to do a better job of collecting data from patients directly about their pain, and be able to organize that in the way that the paper forms that many of us still use are not able to. So Pastor and Promise are something we're working on, but hopefully we'll be able to talk more about that in the coming year. We already talked a little bit about Echo, and with me getting the Theracane pretty hard from Chris, I'll open things up for discussion. All right, knowing that I'm the only thing standing between you and lunch, I will let Chris give you some quick comments about the afternoon's activities, and look forward to seeing you at some of those courses.
Oh, we have one final question.
Yes, I apologize for holding up everybody. So sorry. All right. My question is actually tri-service related. As a osteopathic physician, I have found manipulation to be quite beneficial to my patients, to my practice, dependents, pilots especially, since you can't put them on opiates or if you're taking them off flying stats. I have not heard a lot of conversation about manipulation this morning. Unfortunately, I've seen it mentioned on a few slides. My question is why is there a huge push for acupuncture, especially on the Air Force side, when there's, I think, 40% of the physicians are DOs? Why is there not more incentives to try and have manipulation practices? Why is this not being pushed back? Because this is a skill that can be utilized in the PCM clinic that is already being taught to our physicians. They already have the training. They just need more of the incentive to push it out more.
So I'll speak on behalf of the educational aspect. And one thing, for example, we, at every pain skills training, we offer osteopathic manipulation chiropractic adjustment. And also through our National Capital Region, once a year we offer almost a week-long seminar to teach primary care skills in osteopathic manipulation. That's from an education standpoint. From a policy standpoint, I think we're going to hear, three different aspects from our different thought leaders here, and I'll encourage you to come up afterwards, and we can, discuss those service specific and look for something coming down also from the DHA, as Colonel Juncker was explaining. The program that the Air Force is really charged with is more integrative medicine and moving away from just acupuncture to things such as behavioral modalities and physical modalities.
Thank you.
Welcome. And with that, everybody, two final announcements before we have lunch. Remember, tomorrow, come directly to your workshops at 7:30 in the morning. We also have optional yoga at 6 a.m. for those of you that want to be up at 6 a.m. in the Shim C Lounge, Salon C. Finally, remember, you will be getting 2 emails, one for CME. Please complete the evaluation for the CME, and another email that's specifically for us for evaluation of the course. So with that, I want to thank you all for this morning. A big round of applause for Amy Osick and her team who's in our back with Amy Pitzel.